I want to welcome everybody to our first annual invited speaker and welcome Dr. Clanton. He comes to us with a long list of accolades and experience. I don't want to spend too much time reading all this, but basically he's a pediatrician, which you all know. He's a former chief medical officer. He's currently serves as a consultant to NCI on the National Cancer Centers. And you know, the difference, so I have my PhD. My daughter, when she was young, used to say to me, when I said I was a daughter, she said, "But you're not a shot doctor." So welcome, Dr. Clanton. It's a shot doctor. And he's going to talk about the role of regulatory science in the advancement of tobacco control policy.
Thank you. Thank you. I think here's Mark would have been just fine, just fine. For the last 4 years serving as a voting member on the Tobacco Product Scientific Advisory Committee of the FDA, I really got an interesting, deep education in what really is called regulatory science. After having been deputy director of the National Cancer Institute, I had some familiarity with normal scientific processes, the process by which you evaluate grants, for example, for NIH, and normal scientific advisories. But I can tell you, and what I want to share with you, and I hope is relevant to how your TCORs work at some level outside of the science, is my entirely different education, if you will, in the area of regulatory science. And we're going to talk about that today because it is very different. But because the TCORs really are born of a regulatory scientific effort, here I am. You really need to understand the differences between, say, translating science and maybe translating for the purpose of regulation. Because given the nature of the TCORs, you really are a translational entity. You are not a pure science entity. There may be purely scientific and even basic science activities within a TCOR, but I'm here to ask you never to forget, the idea is that you are a translational structure, and next to that, you are actually a translational structure for the purpose of regulation. Certainly NIH will be reviewing your science without any question at all, and will be making judgments on the science coming from the TCORs. However, the ultimate target here is the Food and Drug Administration, and what they are interested in is science that will help them develop policies and interventions and educational efforts that have an effect on reducing the health or harmful effects of smoking. Never forget that. And if anybody needs to just sort of write down what did Dr. Clanton talk about, write that down. You can go to lunch now. It's about paying attention to the regulatory science aspect of this, and that's what this is all about. Some of the background slides I'll probably skip over because you got some details about the act that allows FDA to sort of do this. But a few things by virtue of disclosure. Yes, I was an inaugural member. My 4-year term has expired. For reasons I'm not entirely clear, the FDA has asked to keep me on as a special government employee, and I'm just disclosing that as well. There are some special restrictions sometimes on SGEs as opposed to an independent scientist, and I'm letting you know that. My views are my views, and they are not the views of the FDA, of Congress, or anybody else. So that's a very important disclosure. And I have no money, so there's no financial disclosure. Key concepts I'll go over, and we'll go through this fairly quickly, are that the TCORs really are translational engines. And they are translational engines, not just in the traditional scientific sense, but in the sense of producing evidence that will be relevant and useful for the purpose of regulation formation. I will probably tell you a little bit later on, and I discovered this actually preparing for this talk, but I didn't know that regulatory science is considered a subset and a subdivision of translational science. I thought I knew quite a bit about translational science. You know, you have basic science, you have that basic knowledge is in translated into tools and techniques in healthcare for diagnosis and treatment, and then those things move through a regulatory process and then make their way out to the market, healthcare market, if you will. But it turns out that regulatory science is actually a component and a subdivision of translational science, hopefully making my point even more strongly, that as you work through creating the evidence, collecting the evidence, at some point in the process, you need to think very carefully, can we make this, well, first, is this useful for FDA in terms of what they're trying to do? If it isn't useful, is there something we can do with the knowledge and the science we're creating to make it more useful? Because in the end, you will be judged in terms of renewals and that sort of thing by how useful the information is as it relates to the regulatory process. I'm currently part of a $75 million translation or transdisciplinary effort called TREC. This is a transdisciplinary research in energetics and cancer. It's supposed to be scientific efforts to look at the connection between weight, overweight, and cancer. The first round of these wonderful projects, this is the second round of this, actually none of the centers were renewed. Every single one of those centers produced great science and wonderful papers. And this is the point I'm really preaching to you on. In the second iteration of TREC, Transdisciplinary Research in Energetics and Cancer, at least the one I advised at WashU, we wanted to make it clear that your job is not just to do great science, because that didn't seem to work really well the first time around. Your job is to do great science, but also think in an integrative way about how the knowledge that's created, or might be created, in terms of creating a hypothesis in the first place that might deliver something that's transdisciplinary and then useful. Think about that throughout the entire process. And then there's an opportunity to maybe look really wonderful, not just with great science, but we thought about why this needed to be transdisciplinary, and we thought about why the connections needed to be made. So TREC is a great example. There were the T-Turks before that with tobacco, and now there's TREC. And my point is I'm going to try to convince you to pay attention to the fact that this is really a regulatory translational science process and not just about creation of knowledge. By the way, I have absolutely no concerns about the science that will come from the Texas project, none at all. I think you'll do wonderfully well. But I'm here to tell you that there's more than just that science to be concerned about. So a little bit about knowledge. So you guys are all bright and you know what epistemology is, sort of the study of knowledge and how we know what we know. Well, I don't know that we think very often about epistemology and health, but here are a few thoughts that, again, I'm going to try to pull you towards this idea that it's not just about pure science and wonderful science, it's about science that can be translated for human benefits. So epistemology is that branch of philosophy concerned with the nature and scope of knowing and knowledge. But I found there's a practical aspect that will draw you towards translation. It turns out epistemology is not just about pure knowledge. Epistemology actually helps us understand where the concepts of pure science came from, science for the sake of science. It sort of comes from this idea of studying knowledge and knowing how we accumulate knowledge, and accumulating it may just be sufficient on its own. But there's a piece in the middle here of epistemology that drags us towards translation for the use of human beings, because we're talking about health. And this is that epistemology also focuses on how knowledge relates to the connected notions of truth, belief, and justification. And those things, I think, actually connect very nicely to human health and the research we do in human health. So epistemology certainly provides the philosophical underpinnings of basic science, that is pure science and science for itself. However, there are pieces of epistemology that pushes towards you have to use the information, you have to care that the information is going to be used. This is not a purely philosophical discipline. If you're involved with health, healthcare, public health, at some point you have to care. Hopefully in the beginning of hypothesis generation, hopefully in the middle of data collection, hopefully in the process of analyzing the data and publishing the data, you have to care very much about, can this be used for the purpose of improving the human condition? How might this be used? Are there additional things that I might do to make sure that it can be used and used well. This author, Dr. Fang, actually was writing a paper that was entitled Lost in Translation, Basic Science in the Era of Translational Research. And it was an argument about we may be talking too much about translation and we don't want to lose basic science and the purity of basic science. But embedded in his own argument about shrinking translation and making basic big and healthier, he also said this in the same paper. Hence, we do not view basic and translational science as one being more important than the other. Remember, the purpose of this paper, the thesis, is that basic science is so important that it shouldn't be overshadowed or diminished in any way by translational science. But he says that one shouldn't be more important than the other. Rather, they are complementary, with the important distinction that basic science findings often precede the activities in translational science. This was really cool. He also said, as we noted, the observations in translation or applied science can generate new questions for fundamental research, as illustrated from I think the interesting fact that vaccinations were created before the field of immunology. Okay, before the research entity was created, we actually had vaccines and learned a lot about vaccines. So you can actually go from translation back towards basic science, and from basic science to translation. And his last point here is that there is a bidirectional flow between translation and basic science. But I want you to care a lot about translation because regulatory science is born of translational work. So the study of knowledge and knowing speaks directly to the belief that scientific inquiry for its own sake is sufficient. However, the epistemological notion of truth, which is evidence, okay, in research, and belief, behavioral evidence, are also central to the understanding of the human health and research in human health. Biomedical and public health research will always target the ultimate goal of how do we use this information, how do we translate that information coming from basic research for the purpose of preventing premature death and the elimination of suffering and disease. So I think I've made at least a solid point that your T-cores are about translation and you need to think about them the entire time. So the findings that will come from the T-cores will inform the general scientific field, as you wonderful scientists always do. You will publish your papers and they will be read widely, I'm hoping. But in fact, remember, because of the unique nature of who is funding you and the reason you're being funded is that tobacco regulatory science is a target, tobacco regulatory policy is a target of the knowledge you create, that tobacco legislation, I would hope, would be served at some point by what you learn and how you publish it and how you disseminate that information. And of course, anything you learn that creates an intervention at the human level, population level, and the individual level are high utility, high value bits of knowledge, which will be viewed by the FDA and the NIH when you are reviewed very favorably. Again, it's not just the science you're doing in the good science. It's going to be more than that. My buddy Goethe said, and is relevant to everything we talked about, knowing is not enough, we must apply. Being willing to apply is not enough, we must do. Translation, translation, translation. So, where did the FDA get this? In 2009, probably one of the last times there was a bipartisan effort in Congress in recent years. There was an overwhelming positive vote in both houses, bipartisan support of this legislation that created the Family Smoking Prevention and Tobacco Act that gave the FDA its authorities. And of course, you've heard a little bit about that in the introduction. One of the things I wanted to get to beyond the details is that the secretary, it's interesting, the language of the law doesn't just say, oh, FDA, go out and regulate. It actually says the Secretary of Health and Human Services is actually responsible for the regulation of tobacco. And oh, by the way, language in the legislation, the FDA can do certain things so that the secretary is allowed to do this. I think it's very important because we should always remember that The FDA is actually the penultimate authority here. It's actually the Secretary of Health and Human Services. And the reason that's important is that it does allow for advocacy efforts, either supportive or critical, to go beyond the FDA, over the FDA, and directly to the Secretary, who is actually responsible for tobacco regulation. But the FDA is sort of that conduit by which it occurs. The Center for Tobacco Products was created in the FDA as part of the law, and the Tobacco Products Scientific Advisory Committee that I sat on was also created in that process. The committee that I sat on is allowed to review any new tobacco product for purposes of extending claims, making claims, and the committee also can provide recommendations directly to the Secretary. I found this interesting because there was nothing in the proceedings of the last 4 years that the FDA has said, by the way, if you need to say something to the Secretary, here's how that's done. But the legislation actually allows this advisory group not just to advise the commissioner of the FDA, not just the Center for Tobacco Products, but the law actually provides and makes provisions to provide advice, scientific, pure, basic, translational, regulatory advice directly to the Secretary. I'm not sure that authority has been really used yet or whether that's been figured out, but something for you to know, and now you guys are way smarter than anyone else about the law. The TPSAC can review safety, dependence issues, any issues related to nicotine, increasing it, decreasing it, any issues related to harm reduction, which, ladies and gentlemen, from the industry's perspective, they have been pouring quite a bit of money and quite a bit of effort, and they are ready, from their own perspective, to be honest with you, after listening through hearings, they are ready to come out full force with proof that allows them to make harm reduction claims. So public health, once again, public health scientists, once again, do not get caught. The industry is ready to move forward on harm reduction claims. I'm not sure how you can actually make a harm reduction claim on a product whose proper use is intended to kill you, but understand they are ready and they are well prepared to make harm reduction claims. And by the law, by virtue of the law, the Tobacco Products Scientific Advisory Committee is supposed to review that and speak to those things. What is also interesting is there is the potential of hundreds and potentially thousands of new applications of tobacco products, versions of tobacco products, that will make all sorts of claims, some harm reduction, others, that could actually come on an annual basis of the FDA. And what has not yet been figured out is how in the world could that volume be handled in terms of a review process in the regulatory setting. Haven't figured that out yet. And in the last year, we did talk a little bit about that. And interestingly, the TPSAC also gets to advise the commissioner quite directly. We talked about nicotine levels and harm reduction. Bad slide. You know why this is a bad slide? Because one of the things that was not regulated by the FDA and not reviewable by the Tobacco Products Scientific Advisory Committee were electronic cigarettes. Why in the world did I throw that up? It turns out there is an effort or near-term effort to bring that into the mainstream. But the way they defined tobacco products, which was their direct connection to the industry. Remember, the industry had a lot to say about this law and how it was written. But the way tobacco products, the definition is written, e-cigarettes were not part of the definition. Consequently, the FDA, at least initially, decided to say, we're going to regulate this as a device and not necessarily a tobacco product or other product. Theoretically, not even theoretically, practically, you can actually synthesize nicotine. So in a way around regulations, synthetic nicotine could be engineered, could be delivered through an e-cigarette, totally unregulatable by the FDA, but that hasn't really happened yet. The TPSAC also was required to deliver a certain set of congressionally mandated reports. The first report that Congress demanded of the TPSAC was a review of the impact of menthol on public health, particularly on the health of children and special populations. When we got into the data, which were several thousand pages of scientific research and reviews, we discovered that it would take probably about 3 years to carefully review that information and then come up with conclusions. We were given approximately 4 months. So I'm going to leave that here because I could talk for hours about the menthol report. I wrote on 4 chapters. I'm not in, I doubt if anyone on the planet has actually read that report because it hasn't been disseminated. It's been left up on the FDA site, but there are roughly 400 pages that we looked through or wrote initially on that report. And one of the best pieces of it actually was in the area of marketing. Dorothy Hatsukami did a beautiful job authoring that section on how menthol cigarettes are marketed to youth and to kids. And I would really recommend, if you're interested in probably what I think is one of the most fascinating elements in tobacco, read the report, because it turns out, number one, menthol is carefully engineered, scientifically and carefully engineered in cigarettes. And menthol, in my opinion, is actually a pharmaceutical, pharmacologic piece. It is classified as a taste piece or flavor piece. When you look into the science of menthol, it is a pharmacologic agent which probably allows children to initiate, youth to initiate, females to initiate, and could possibly be the reason that African Americans as adults on an 80% level only choose that cigarettes. In fact, the research that I'm involved with a group right now, we're looking at taste sensitivity, because it turns out taste sensitivity is genetically determined. Anybody here super tasters, tasters and non-tasters? We can talk about that later, but super tasters theoretically should not be able to smoke. Super tasters theoretically should not be able to tolerate the taste and the bitterness of tobacco smoke, but menthol may actually, as a pharmacologic substance, carefully engineered, may actually allow certain populations to initiate and to persist. So real quick, I had to squeeze that in there because that's my real interest. Next report we did, congressionally mandated, had to do with dissolvable tobacco products. I don't think we had any big scientific realizations there. And again, more on regulatory science as a subset of translational science. This is just a quick piece to again, remember or cause you to remember that whatever you do, whatever you create, does have to go through a process. And interestingly, I'm not sure I'm supposed to step out of this because I think we have remote viewers, but this is a translational continuum diagram. What I find very interesting about this is to your far left, you see basic science and how that works. To the far right, really, that's actually your healthcare delivery system, where all this wonderful knowledge is used. But what I find so fascinating is early translation, which is called translational science, late translation, which hits your regulatory area, and dissemination are actually all translational activities. Dissemination is actually defined in some literature as part of the translational process. So what I find so fascinating is when you look at if you attach a dollar amount, and I'll do this in another presentation, if you attach a dollar amount to each of these areas, basic, translational, subcomponents of translation, and then to your final healthcare delivery, which of these has the highest dollar amount attached to it? I know you guys know this. The delivery of healthcare takes up the biggest piece in terms of money spent. The next biggest piece is basic science. We're still working at about a $28 billion level, at least from NIH and much more from private industry at the basic science level. What you'll find, this is a qualitative statement. I haven't actually done this because there are no Medicare numbers to pull from, but the translational piece is relatively ignored in terms of money and training and people who are prepared to go and translate. Remember Madame Curie and the discovery of radium. Actually, Madame Curie believed and had made statements that this really had no practical purposes outside of science and knowing more about matter and how matter worked. It was almost by accident that those discoveries, discovering X-rays, et cetera, were translated into a tool that is now used as an X-ray and a common tool in healthcare diagnosis, and healthcare delivery. An accident, an entire accident. And there are many other examples as well. So we have this huge translational piece here in the middle, and I would even break late translation out into two translational pieces, with the second being FDA, regulatory activity. Most of the process is actually translational, but in fact, we don't fund the process in an equal way across this continuum. So in terms of some of the things that a group I'm involved in, we're going to start doing is, as you heard in the introduction, cigarettes and little cigars are not regulated by the FDA under the Family Smoking Tobacco Prevention Act. Don't ask me why, I don't know. It's tobacco, right? But they are not regulated at all by the FDA currently. That could change in future iterations of the law. What is fascinating is, and again, this is not scientific at all, but if you notice these smaller cigarette-looking things, these are actually cigars and classified as cigars. Youth are really going after these things. Part of the reason is they're cheaper, and they actually are taxed in many cases at a lower level and are not regulated at all by the FDA. So it's interesting about how there's an expansion of the use of little cigars, which look like cigarettes, and the adoption of those kinds of products, which are not regulated at all by the law. I find this fascinating is that, I know you know this, you've seen this. To me, this is new information. They're now taking that electronic cigarette, which is not currently regulated, right? And they're putting, it's probably guarana, a stimulant like caffeine. They're putting appetite suppressants. They're putting energy boost, which is the guarana in many of these things, and taurine, there's a couple other those things. And even sleep aids now will be delivered through the mechanism of a cigarette-looking device. One of the major concerns from a legislative and an advocacy perspective is that it may be very difficult to tell the difference between an actual tobacco product, cigarette, and some of these other devices. And there is a concern that if you start on one, you'll end up using the other. And I don't think we have a lot of science yet that will prove that or disprove that. And I think that's pretty important. Very little is known about how young adult cigarette smokers form risk perceptions of flavored little cigars and cigarillos. Some of them actually perceive them at a lower risk and are being told by adults because cigars are lower risk. So the adults have always felt that cigars were a lower risk relative to cancer. And so there's interesting information flowing around where youth may actually perceive cigar and cigar-like products at a lower risk for health. And I think a lot of work needs to be done in those areas. I believe this is an R21, a regulatory R21 that I'm working with this group, Dr. Fagan and Fryer at the University of Maryland as a scientific consultant on this particular project. There are a couple of others as well. Producing, the intended purpose of this R21 is to produce a tool to assess risk perceptions in that particular group. And this is the one I'm really interested in. I'm interested in sensory perception. And is sensory perception an issue that's a target of menthol cigarettes that allows youth to initiate, that allows women, females to initiate, and is potentially the cause for Filipinos, African Americans, and a few other groups to only smoke menthol cigarettes? And this is my principal area of concern. We've got an R01, I think, going in on that. You can read these later, obviously, you know, because here it is. They're up there for you. So, challenges in unregulated projects and research translation. Scientific findings related to these products may not have broad-based population impact to reduce associated disease risk. We don't know. The FDA has been slow to introduce new product regulations. It's been 3 years since we wrote the menthol report, by the way, and we did recommend that menthol cigarettes be removed from the market. We have a model that shows that roughly 1 million fewer people would die if menthol cigarettes. There's a counterfactual scenario where if menthol cigarettes didn't exist, 1 million more people would be alive because of that. The industry has the opportunity to continue to put new products on the market. They are, you've seen some of them, including new nicotine delivery devices. And right now, I think the entire regulatory process is well behind that curve. The industry is way out ahead. We need the T-Cores to generate the knowledge and near-term knowledge that will help the FDA do a better job with regulation. And there are opportunities for the diffusion of new products much faster than the current rate of translation to benefit populations. This is just my overall slide here. Again, the idea is that our translational pipeline is quite constrained. We have these other big pieces of the pie, but once the scientific translation happens, then it goes into the FDA process. I've got this written as a big, robust piece. Actually, it's fairly small. The FDA-like activities in Germany, in Europe, and other parts of the world actually work much faster and much efficiently than the current FDA does. I would say, not just as a special government employee, part of the reason for that is that the FDA is not well funded. When I was deputy director of the National Cancer Institute, I think this brings the point home, my own leadership portfolio was 1.2 billion of NCI's 5. 1.2 billion is approximately what funds in its entirety all FDA regulatory activities. So although I've got a lot going on in the FDA translational piece, it's still relatively small and probably needs to be funded at a much higher level. The last point I think is TCORs, although are not transdisciplinary, they really need to be team science related. And wherever your scientists and those involved working with the TCORs are bringing in different kinds of people from different disciplines in a maybe not transdisciplinary, but a multi or interdisciplinary way, you will be better served in terms of what comes out the other end of that research. Team science is a collaborative effort to address scientific challenges. Oops, let me go back. Team science is a collaborative effort to address a scientific challenge that leverages the strengths and expertise of professionals trained in different fields. That comes from NCI. Single individual researchers must be involved in integrated approaches in their work. It does bring together researchers who would otherwise not work together, and it provides opportunities to raise and explore hypotheses that otherwise would not be addressed. So team science is going to be very important to your TCORs. Collaborative research approach. You're developing scientific knowledge for the regulatory process, and we want to be able to create and synthesize that knowledge for the purpose of regulatory action. Now, this is a statement, one more slide, hang in there, thank you. This statement from a Nobel Prize winner. I would modify this because I actually think basic science is pretty important. I'd like to see a better balance between basic and translational, but this is Sir William Bragg's statement. The important thing in science is not so much to obtain new facts as to discover new ways of thinking about them. This is a person who will never be a Nobel laureate, but I want to leave this with you as well. The highest, and I believe this, the highest and best purpose of biomedical science is realized when the knowledge derived from research is used to improve the human condition. I believe this, that's why I'm here today. I hope you believe it as well. Better science for human beings is what we're all about. Thank you very much.